All right, good morning, everybody. My name is Dr. Harpuck, or John. I've met a lot of you guys in the doors of the nursery or in my delivery. Today I'm going to be talking about pediatric heart murmurs. I know a lot of you guys take care of pediatric patients and adult patients, so I've sprinkled in some information on adult murmurs as well, mostly for completeness. We can go ahead and get started. We can go to the next slide. So today we're going to be talking about, first off, is describing heart murmurs. The way you talk about heart murmurs is really important. So we'll get into the right way to describe your exam findings to each other. The next thing we'll go through is a couple of specific murmurs. We won't go through every single murmur that's out there, but we'll talk about the most important ones, the ones that you see most often. Then at the end, we'll talk about how getting a good history on murmurs is really important. And then we'll go into a summary and talk about a case that we've seen here at KDH to try to tie it all together. All right, so first off, what are the normal heart sounds? I'm getting this is probably pretty hard for you guys to see on this side of the room. So there's two heart sounds, or your typical heart sounds, your S1 and your S2. What is made by those, or what makes those sounds is the closing of normal valves. In a normal heart, you should just hear those two sounds, the S1 and S2. Between S1 and S2, in that space is the systole, where the heart is pumping out blood. Knowing and being able to identify those direct two sounds, and knowing when is systole and when is diastole is the first step in identifying a heart murmur, so that you can talk about when that heart murmur is happening. So getting into describing heart sounds, as I was mentioning, figuring out the timing of the heart rate is the most important thing. You can describe murmurs as being systolic, or diastolic, or continuous. Within each of those, there are modifications. You can say it's early systolic, slow systolic, and diastolic, different modifiers on that time. That time piece is going to be the most important part of when murmurs are, as that's going to be what is telling you normal versus abnormal. That can tell you where that murmur is happening as well. The second thing is describing the shape of the sound. Is it getting louder as it's happening? Is it getting softer as it's happening? Some murmurs will only occur and then they'll just fade away as they're happening. Those are very important features to identify. The next thing is the location of the murmur. We can go to the next slide on this. So when looking at a murmur, there's different locations you want to do on your typical exam, or standard cardiac exam. You want to be listening in the aortic area, pulmonic area, the tricuspid area, and the mitral area. So those are the directions of blood flow, and you can hear each of those valves. In pediatrics additionally, you'll also want to be listening along that left sternal border as it goes down. You can hear a lot of murmurs in this area on the side of the sternum. That's where the aortic outflow tract is, so any of the murmurs that are happening in the aorta, which we'll get into, those can be heard estimating that. Also in your exam, you want to feel where that apex, where that in that mitral area of the apex of the heart. Sometimes the apex of the heart can move, and that can tell you information about an enlarged heart as well. Next thing we want to talk about in describing murmurs is radiation. If you can hear them here, you can hear them anywhere else. If you can hear them here, you can hear them anywhere else. Often you want to listen to the carotids as well. That's more for adults, where you hear murmurs that tend to radiate up towards the carotids. In pediatrics, you want to listen towards the axilla and on the lateral chest as well. Next is berating murmurs. How loud is it? Is it soft, barely audible, or is it the kind of things you can hear without even the stethoscope touching the patient? Generally, the way that we look at these is if you need a stethoscope to hear it, but there's no movement of the chest, no thrill, then you would grade it 1, 2, or 3. Once you're able to feel a thrill on the chest, which is the movement of the skin or of the chest that you feel with your hand, sometimes you can feel it through your stethoscope, then it becomes a 4, a 5, or a 6. Being able to grade these is important because different murmurs will present as softer, different ones will present as loud. And then being able to talk about the pitch of the murmur as well is important. Is it high pitched? Is it medium pitched? Or is it low pitched? So if you're, I know it sounds kind of crazy with me making sounds up here, but if you're able to do that as you're thinking about it, like, is it a pitch that's very hard and harsh? Is it a pitch that's low and soft? Additionally, the quality of it, again, these I find are easiest if you start to make the sounds with your mouth. Is it blowing? Is it harsh? Is it rumbling? Or is it musical? Each of those qualities will clue you in towards different types of murmurs and can tell you, is this something that I need to worry about, or is this a kid that I can send home and have them see the next time, or have them listen to the next time they come back? And then lastly, there's a couple of exceptions for ways that murmurs can vary. Sometimes they're louder in different positions. Sometimes you'll have them sit down, you'll have them stand up. Oh, it got louder when they stood up. That's a big problem. Is it going to be something where you can have them lie down and then you can lift their legs up? And does that change their murmur? That's giving an additional rush of blood towards the heart and will change the hemodynamics, change the loading conditions in the heart, and sometimes can change our murmur for it. All that information, if you're able to present that and able to use that to diagnose a murmur, can really distinguish problematic murmurs from normal murmurs. And we'll get into this in just a second. We'll go to the next slide here. So getting into systolic murmurs. Almost all patients at some point in their life will have a systolic murmur. Some people say it's 100% of patients will have a systolic murmur at some point. It just depends on can you get the patient into a position or into enough dehydration, enough exercise where you start to do that murmur. Sometimes you just get a really wide murmur. So the ways that systolic murmurs will sound, it can be normal flow through normal anatomy, just increasing flow. Those are your aortic murmurs, and those often are based off the size of the vessels. It can be normal forward flow across the problematic valve. Those are your aortic stenosis murmurs, your in systole, your aortic stenosis, your pulmonic stenosis murmurs. It can be backwards flow across a problematic valve. Those would be your mitral regurgitation and your tricuspid regurgitation, where blood is going the wrong way and making it septic. And then last thing you would hear during systole would be those VSD murmurs, and we'll talk more about those later. And then in the within systolic, there's early systolic, there's mid systolic, there's holosystolic. Those are the typical timings that you hear for murmurs. In terms of mid-systolic murmurs, these are the most common murmurs that you hear in pediatrics. When I was saying about 100% of patients will have a murmur, these are the ones that you can usually get patients to have. They tend to be that blowing crescendo, decrescendo. So I'll start making sounds again. It sounds like, and you can hear in my voice and in the way my hand is going, it's blowing and it's up and down, up and down, up and down. Each time the heart is beating and it hits that maximum ejection rate is when you hear that beat in the sound. These can be classified as innocent, physiologic, or we'll go through each of those. Sorry, next thing. So the innocent murmurs, the Stills murmur is the one that you'll hear in a lot of young children. This is something you hear probably in your under 5 outpatient clinic. These are the ones that have that musical sound to them. Often they're heard, we're talking about in a pediatrics position where you want to listen to right along that sternal border. And they tend to be louder when a patient is lying down. So that's something that is an important distinguishing factor to distinguish it from open, which is one of the problematic murmurs we'll talk about in just a second. This is part of the reason why you want to lie patients down or have them stand up, is to see if you can make that murmur change. These are talked about as being vibratory or musical. Once you've heard a couple of them, you'll be able to pick these out really reliably and say, like, that really sounds like a Stills murmur. These are reassuring features and the kind of thing that you can, don't need to do any further imaging, and you can feel confident sending that patient home for the next follow-up visit. The other thing that you'll listen to often for mid-systolic murmurs is pulmonary flow murmurs or peripheral pulmonary stenosis. For these, I put up the age as less than 0 to about 6 months. These are common in the preterm infants, which is why I'm saying they can happen at less than 0 months old. And often they are heard out on the sides of the chest here, as blood is flowing out to the lungs and plowing through narrow arteries towards the lungs. That's when you'll hear those. And the blood is flowing out to the sides of the chest, and so you listen on the side of the chest. And then the last one is the aortic outflow murmur. Sometimes we call this the athletic murmur. This is for kids that have a low resting heart rate, often in the 50s, and have a large stroke volume. So this is kids that are working, kids that are running around a lot, your soccer players or your football players that have a large ejection volume. As all that blood is going through the aorta, you can often hear that. This typically happens around age 10 to about age 20. I put it 11 to 18 as probably the most common range where you'll hear that. Again, loudest on that left sternal border. These tend to be fairly soft and have that volume volume. We go to the next slide. Then the next one we want to talk about is cardiomyopathy. So this is where we're getting into murmurs that cause rockers. And this is the one that, if you're going to listen to one murmur here, this is the one to remember from this talk. It's one of the murmurs that, or one of the heart problems that presents with a murmur and can pull patients to side. So hypertrophic cardiomyopathy is when the muscle of the heart overgrows, gets too thick, and that can cause closing and narrowing of the outflow towards the aorta. So that's the blood that's going towards the body and get pinched off. This is the muscles in the heart that are getting closer. And so it's not a fixed obstruction like in a valve where that valve is a particular size. This murmur will change as the patient is moving. If you put more blood into the heart and stretch out that outflow tract, then that murmur is going to get quieter. If the patient is dehydrated and has less blood flow and less loading in the heart, that murmur is going to, that tract is going to get narrower, and that murmur is going to get louder. You don't have to dehydrate the patient to get them to have less blood flow going through their heart. This is the one where it's important. You hear that murmur is solid. Get the patient to stand up. As they stand up, suddenly less blood is going to be coming back to the heart, and they should be having less blood flow, smaller stroke volume for the next couple of beats, and then that murmur should get a lot louder. That's the opposite of most murmurs, so this one behaves the opposite way, which is really helpful. Similarly, you can have patients lie flat, or you can lift their legs, increase the volume that their left heart is seeing, and then that should cause this murmur to get softer as you're moving those problematic muscles of the heart and letting them have more unrestricted current. The last thing you can do is if the heart has to pump against something that's more difficult to pump against, it's going to have more pressure and help keep those muscles apart and keep that murmur quiet. So that's when you talk about having the patient squat, or you can have them do a hand grip, or you can have them flex their arms. All of those add resistance to the circuit the heart is pumping against and help keep that outflow tract open. So this is why you have your murmurs stand up. It's open. It's a risk for sudden death. Generally, these kids you recommend not doing vigorous exercise. People can live with this, and it's something that's it's challenging. There are corrective surgeries that I don't know if they are available at PCH. The next one that I wanted to include briefly is aortic stenosis. This is very rare in pediatrics. I don't think I've seen any patient with aortic stenosis in my pediatrics career, but it can happen. I included it here more for adult murmurs. We'll send out the slides at the end so that I thought this for a moment. And then the early systolic murmurs, acute severe mitral regurgitation is the one that I wanted to highlight here. This can be seen in, so the mitral valve, it should be preventing blood flow from going backwards during systole. If it is incompetent, if it is letting blood flow go back, you'll have blood that just moves back and forth across that mitral valve and lead to the left ventricle just getting dilated by more and more blood. pools in that outside of the heart. That process takes a long time, but it can eventually lead to heart failure. There's a couple of different scenarios that can lead to acute microregurgitation. The most common ones that you'll see are trauma. Any sort of trauma to the chest can damage the valve, can damage the muscles, can damage the chordae tendineae. And then also with rheumatic fever, we just heard about a case that was a rheumatic fever. That can similarly damage that valve and cause that blood flow to go back. Small muscular VSDs and tricuspid regurgitation, I included those here for completeness, but generally we'll talk more about VSDs in a moment. And then your holosystolic murmurs. These all go back to making funny sounds. Shh, 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 shh. There's no change really in the murmur as it's going, and it goes all the way from the first beat to the second. So it's continuous for that period, and then goes down. Shh, shh, shh. So the first one I wanted to talk about is a ventricular septal leak defect, or a VSD. These are the most common congenital heart defect you'll see. About 1% of children overall are born with some sort of abnormality in their heart. This is the most common and tends to happen in about 3 to 4 out of every 1,000 children. So you'll see this in your nursery for having 1,000 babies a month. You'll probably see this about once a week. This is generally, I guess we'll get into the challenge of that, because you'll probably send these kids home the same way that we do in the rest of the world. These usually present as kids that come back to the hospital sometime in the first 3 years of life. Depending on how large that the hole in their heart is, that will lead to problems earlier. Generally, these patients are presenting with a pretty strong cardiac history and can present in heart failure. They can present in extremis where they're really acutely failing in that way. In terms of cardiac history, we'll get into a slide on this in the end, but it's asking important questions that are assessing how a patient's heart is functioning when it is stressed out. For babies, the most aggressive exercise that they do is feeding, and sometimes pooping. That's their marathon, is feeding. So for them, they're having a lot of trouble with feeding, which is frequent pauses, sweating, shortness of breath. Those sorts of questions say patient has a murmur, and those sorts of things are big red flags. This patient is really working out just to feed. That's a problem. The other thing that you could get in history for these patients is poor weight gain. If your heart is pumping extra blood, that takes extra calories. So if they're not gaining weight after 2 months, after 3 months, after 4 months, that's a clue that you would want to start asking more cardiac questions. For these, often at birth, you will not hear any murmur. The pressures in the heart at birth on the left side and the right side are pretty equal, and so there's not going to be any flow across that hole. As they get older and the pressure in their right side of their heart starts to go down, then you'll start to hear flow going across that hole from the left to the right. What this leads to is over circulation of the lungs. So blood is going across from that left to the right and going right to the lungs and going back to the right, to the lungs, back to the lungs. So it creates this small little loop in the chest where more and more and more blood is going to the lungs. What that leads to is the lungs realize that there's extra blood going to them, and they start to hypertrophy, the muscles start to grow. That leads to increased resistance in the lungs, and as that process continues, they develop pulmonary hypertension, and then if that process continues, eventually they'll lead to so much resistance in their lungs that instead of shunting across, the shunt will be in the opposite direction. That's when we talk about Eisenmenger syndrome, and when these kids start to come in with cyanosis, with low oxygen saturations, that process is towards the end of life generally, but that's how patients with VSDs tend to respond. That process can start as early as about 2 years with patients with very large ventricular septal defects, and present later with patients that have smaller or more significant. Small VSDs tend to close on their own. About 90% of small VSDs will close on their own. And VSDs that are small tend to make very harsh, loud sounds. It's a bit counterintuitive, but if you think about if you were to have a hose or a tap, if you were to have it just barely open, or put your finger over the end of the hose, you'll make it spray. The smaller you make that, the faster the jet is going. The faster it goes, the louder, the more turbulence you're going to hear. So the small VSDs tend to be very loud, very harsh. The larger VSDs can be pretty big. They for a baby, that's huge, but they can be fairly large. They can be larger than the aorta. For those, they tend to be pretty quiet. You don't tend to hear much of any sound from the really large VSDs. So they can be tricky to find, and they can happen. These are, again, part of the reason why you have to ask those cardiac questions to these patients, even if they have a very slight murmur or even no murmur at all. Those sorts of questions, like the sweating of feet, the couple of feet, the full feet, those are all big red flags you want to pay attention to, even if the patient doesn't have any. I included a graphic of what a VSD looks like. I'm just going to walk over and up in the top right, we have what a normal heart should look like with its 4 chambers. And then down here, we've shown a VSD. You can see that there's that large hole in the middle in that circle. And they're representing that blood flow can cross in either direction across that. As we talked about, tends to go right to left. Tends to go left to right early in life, and then switches directions later and goes right to left. The other whole systolic murmur we want to talk about is mitral valve regurgitation. We talked about acute, severe mitral valve regurgitation earlier. They can often be seen in rheumatic fever. This tends to be the chronic version, whereas in its whole systolic, it's across the full mitral systole. Again, leads to the same problems, and this can be seen in late rheumatic fever as opposed to early rheumatic fever. The diastolic murmurs, these are, instead of these tend to be early and fast and are always problematic. This generally represents blood flowing in a direction that it should not. So it's either blood going from the aorta back into the heart, or from the lungs back into the heart. These tend to tell you that there's a problem with a valve, either the aortic valve or the pulmonic valve, and it's letting blood flow go back in the direction that it should not. The early decrescendo, those are tend to be aortic regurgitation. The other thing that can cause the diastolic murmurs are mitral stenosis or tricuspid stenosis. When in diastole during the heart filling, is when you can hear blood flowing across a stenotic or mitral or tricuspid. For aortic regurgitation, I've again included this for completeness. It tends to be quite rare in pediatrics, but you can hear it at best in that in the aortic area or in that left side in the pulmonic area as blood is flowing back in this direction. It can be heard there on this side. And then it tends to be quiet and can be high pitched, and so it's something that you can mix with red sounds. This is one of those murmurs where if you think you might hear it, you want to have your patient to a threshold. And then you can get their breathing and stop doing that. I mentioned that for the adult murmur because good luck explaining how to do that for a 4-year-old. I can never get the young kids to hold their breath for me. So 4 years for the adult. Then the continuous murmurs. In pediatrics, the big one we talked about is patent-ductal arteriosus, or PDA. These tend to be heard in the nursery or in the birth exam when a baby is born. These are those harsh, continuous, machine-like murmurs. If you think you're listening to a washing machine and not a baby, then you probably got a baby. These tend to follow with the pulse, so they can go up and down a little bit in variation, but you'll hear them continuously. It's blood flowing back and forth through that PEA, and it'll be continuous. It'll keep reversing directions, or it can be continuous modulation. The other three that cause continuous murmurs I've included here just for completeness sake. Cervical venous hum is blood returning into his heart from your head and neck. Usually if you hear those, it would be in a kid that's 2 or older. Some of you can be pretty certain does not have a PEA. If you want to confirm that it's a cervical venous hum, you just apply a little bit of pressure on the side of the neck. Usually do one side and then the other, so you're not choking with it. And that should make the murmur go away, it's just stopping that blood flow. In pregnant patients, you can hear increased blood flow through the breasts, and then not a murmur, but something that would be continuous is a pericardial friction. So if you're hearing that friction rub sound, that as the part is rubbing into the pericardium, that tends to be fairly continuous and strange. So let's get back to the basics. Things that you're trying to figure out: where does your murmur occur? When does it occur? And where is it the longest? About 1% of children will have some sort of congenital heart disease. So about 1 out of every 100 will have some form of hole in their heart. The most common of those is being a VSD. A lot of these will present with murmurs. So this is a common problem that you're going to see a lot. If you're seeing 100 kids in the week, you'll probably see one kid with some form of congenital heart disease. Perfect. We just got 2 or 3 more slides. And then things to watch out for is the diastolic murmur, the holosystolic murmurs, and if they get louder than standing, or a PEA. We talked about getting a good history already. We can skip through this slide. And then I just want to talk quickly, if you have about 2 more minutes. Is that okay? This is a clinical case that we saw here yesterday. This is a patient that is still here and wanted to talk about them briefly. So this is a 3-month-old male. He had a history of pneumonia about 2 weeks ago that he was treated for. He was coming back into ADH with a chronic cough, significant chest indrawings, and then for some more history, normal birth and normal weight gain for him. Big red flag for him is that he's had a lot of sweating and pauses with his eating, and then also he's got that chronic cough. On his exam, he has a 1 out of 6 holosystolic murmur. It was best heard in the left lower sternal cord. There was no radiation. His heart rate was about 120 yesterday when I saw him, and his saturations were around 99%. He was afebrile throughout his course, and he had respirations of about 40 with some crackles at the bottom of his lungs on both sides, and then he also had significant chest indrawings. This was his chest x-ray. It'll probably be challenging for you guys to see, so I can describe what the findings are. He has an enlarged heart, not enormous, but slightly enlarged for his age. His heart has a boot shape to it, which is means that it's enlarged out on the patient's left side most prominently. This often is an indicator of left ventricular dilation and can be a problematic finding. This can be seen in VSDs. It can also be seen in pathology of flow. He also has increased vascular markings in his lungs. So you can see the veins going out to his lungs, or the arteries going out to his lungs. Those seem to be engorged and enlarged. And then the last thing that we see, apex tends to be nice and tight to the diaphragm. And instead of being close low down to the diaphragm, it's a little bit elevated off that diaphragm. Again, that's an indicator of an enlarged heart. We did some labs for this patient. He had a glucose of 112 we were checking at the bedside. And then we ordered FBC and chemistry. For chemistry, we're looking at cardiac function electrolytes such as potassium and potassium. And then for an FBC, it would be good to know if this patient has anemia, which could cause him to have this murmur, or if the patient has some elevated. We got a cardiac ultrasound here. That was normal. But just a quick note, the cardiac ultrasounds are not a good replacement for a full congenital echo done by someone with experience in pediatric echocardiograms. You can look at the valve, you can look at the septum. The patient continued to have significant chest indrawings, and I don't know where the next step is for this patient, but we talked yesterday briefly about this patient that someone to be transferred to PDH for further imaging and further confirmation. And the concern here would be that this patient has a large VSD with that enlargement of the heart and that Polish style like 1/6 murmur, and all of those concerning features of this experience study with these to cause this chronic cough. This presentation is a lot like the I included an extra slide with VSD and results. Yeah. Thank you very much.